Next, we're going to have Dr. Nancy Miller from the University of Maryland at Baltimore, and she's going to talk about vulnerable populations.
Okay, I'm just looking for my arrows. Okay, I'm ready. It's a real privilege to be here this afternoon and to talk with you a little bit about some of my ideas related to research. I first of all want to kind of compliment the work that's been conducted by the people at the University of California, San Francisco, and people that they've collaborated with around personal assistance services. I want to, okay. UCSF missed my compliment to them. Sorry about that. I think that there's been really quite good work that's been presented today related to personal assistance services and our ability to move forward. I'm going to focus on a population or group of people that we really haven't talked a lot about today, and do just a few things here. I'm going to first of all talk about, we haven't really talked about nursing homes and not about nursing homes, but I want to talk a little bit about the changing composition of the nursing home population, particularly as it relates to working age people. Then I want to talk a little bit about what we know about working age people who are at risk or in a nursing home setting, look at some trends that relate or will impact them in their use of either community-based services or institutional services, and then kind of outline what I see as some research needs related to vulnerable working age people, and then finally note some federal and state policy initiatives, most of which we've touched on already today. You may or you may not know, but working age people between the ages of 18 and 64 have a growing presence in the nursing home population. This comes from the Centers for Medicare and Medicaid Services. And the growth there has increased between 2000 and 2004 for every single year. And it's concentrated among people who are ages 31 to 64. We don't see growth in children and youth. We don't see growth in kind of the younger adult population. The growth is really in kind of an older working age population. We saw the growth in every single state and every single state and the District of Columbia, and we saw particularly large populations in Alaska, Illinois, Louisiana, Arizona, and California. I used the behavioral model of healthcare use to just profile a little bit what we know about these people. First of all, I'd like to acknowledge that this particular study was a study that was funded by NIDER. And what we did in the study, Marcy Weinstein and myself, was that we interviewed a little over 200 working age people who were in 17 nursing homes in 7 counties in Maryland. And the focus of the study was to really look at the circumstances that brought them in and the barriers to coming back out. But I just want to talk about them a little in terms of what they look like. In terms of kind of traditional characteristics, over half were never married, 2/3 were black. They had relatively low levels of education, with almost a half not receiving a high school education. Prior to the event, most people came in through the hospital, but before they came to the hospital, about 12% lacked a home before they came to the hospital and then into the nursing home. 24% were with a family member. It was typically either a parent or a child, depending on the age of the person we interviewed, and about 14% had been in another institution. What I found particularly interesting is, I think sometimes we may think that there's a lot of Medicaid involvement here. While a lot of people came in were covered through the Medicaid program, we had about 28% who were actually uninsured at the time that they had an acute event that brought them into the hospital and into the nursing home. Only about 2/3 we asked them about people who were involved in this decision, and about 2/3 had a family member or a friend involved in the decision. And a critical part of implementing the Olmstead decision, it seems to me, is that people need to know and be involved in the decisions about long-term care. And in our study, we had about 26% who didn't even know who the person was who'd made the decision, suggesting that they were not involved. They had fair and poor health status. The conditions I give here are conditions that were also identified by Mary James and Brant Fries in some work that they did with the minimum data set. We see a lot of cardiac conditions, diabetes. We had a lot of people with HIV/AIDS, paralysis, and developmental disabilities. Through the center work this time, we did some additional work interviewing more people in San Francisco and the District of Columbia to see if there might be some site variation in this population. And just a couple of things of note, we found that participants in San Francisco were more likely to have been in a single room occupancy before they came into the hospital, into the setting. Washington, D.C. had higher numbers of people who were homeless. There was less family involvement in both of those sites relative to Maryland. Diabetes was quite prevalent in the Washington, D.C. participants, and HIV/AIDS we continue to see in San Francisco also. It seems if you're going to be involved in making your decisions, you have to have some knowledge about your care needs and options. And we found that in many instances, people didn't know a lot about their needs as measured by expected length of stay or other places where they could be receiving their care, again suggesting that they had not been particularly involved in the decision to be admitted to the nursing home.